to the second session of this day's proceedings. We are here to hear all the free papers which are being presented. And without wasting too much time, we go on to the first speaker, who is Dr. Anu Tandon. Is Dr. Anu Tandon here? Right. Anu Tandon is going to speak on her paper of safety of bilateral simultaneous intravitreal injections of anti-VEGF in various retinal disorders.
Good morning, everyone. My topic is safety of bilateral simultaneous intravitreal injections of anti-VEGF in various retinal disorders. No financial disclosures.
They've not started the timer. Okay.
This study is done to evaluate the safety and compliance of same-day simultaneous bilateral intravitreal injections of anti-VEGF. The injection was administered for various retinal disorders like macular edema in diabetic retinopathy, wet ARMD, macular edema in vascular occlusions, and even retinopathy of prematurity. The thought of administering bilateral simultaneous injections in adults came to us when we had given multiple bilateral simultaneous injections in ROP cases without any major complications. This gave us the courage to administer it simultaneously in adults with the earlier mentioned retinal disorders. There has been an increase in the number of intravitreal injections administered, and these diseases might need repetition of injections. So, if there is need of bilateral injection and that is administered simultaneously on the same day, that would be beneficial for the patient. The administration of simultaneous bilateral injections is safe and well tolerated and has been proved earlier in studies also. A retrospective study was conducted from December 2018 to June 2021 on 354 patients requiring bilateral intravitreal injections of anti-VEGF. The patients included were suffering from the retinal disorders mentioned earlier. The drugs injected included ranibizumab, bevacizumab, aflibercept, and brolucizumab. Injections were administered under proparacaine eye drop and moxifloxacin eye drop prior to the injection. Part preparation was done by 5% betadine and separate drapes were used for each eye. 2 separate sets of instruments were used for both eyes. Under all aseptic measures, the drug was loaded by the surgeon in an insulin syringe from the vial and transferred to a new insulin syringe by removing the plunger. Video is not working. The plunger was replaced back and the air in the syringe removed. This is how we load the injection. It's not working. Sterile eye speculum was put, the sclera was marked with calipers, and the injection administered with the direction of the needle towards the center of the globe in the inferotemporal quadrant. A cotton tip sterile applicator was put when the needle was withdrawn from the globe, and paracentesis was done from the anterior chamber. Similarly, the injection was given in the other eye also with separate sets of instruments. Post-injection moxifloxacin eye drop 4 times a day was given for a week. Our team consists of 3 surgeons giving intravitreal injections, and all of them follow the same method for administering bilateral simultaneous injection. A total of 354 cases, that is 708 eyes, were administered bilateral simultaneous intravitreal injections, and the most common agent used was bevacizumab and followed by ranibizumab, and in few cases the other 2. The first follow-up was done at 1 week and there was no major complication seen in any of the cases except subconjunctival hemorrhage in 12 cases unilaterally and 3 cases bilaterally. There was 1 case of lens touch posteriorly in one of the early cases. The injections were repeated in 124 cases according to their retinal conditions after a time period of 1 month. There were no systemic side effects of the injections as the patients were followed up to 3 months in our study. There was no significant difference in the occurrence rate of complications between simultaneous bilateral intravitreal injections and unilateral injections as reported earlier in studies. It can be seen from our retrospective study that same-day simultaneous bilateral intravitreal injections are safe. We have also included premature babies in our study without any major complications. So this practice is safe, convenient, and cost effective for the patients as well as for the hospital staff. Usually this is not practiced because of the dreaded risk of endophthalmitis, which is nil in our study. The application of 5% povidone iodine prior to the injection is a proven measure to prevent endophthalmitis. We can also compare our data of unilateral injections administered at our center in the same period in 418 eyes with only subconjunctival hemorrhage as a complication in 23 eyes. In a previous study of bilateral simultaneous intravitreal injection, the incidence of endophthalmitis was only 0.01%. This is near to the lower end of the range as described in previous reports also. In a survey conducted at US by Green Sims, 46% of retina specialists performed same-day bilateral intravitreal injections, and this is well tolerated by the patients as none of them refused any further bilateral injections. So we can conclude that administration of bilateral simultaneous intravitreal injections is safe and can be conveniently given in the same sitting. The number of patients visit to the hospital is also minimized, which is a need in the present corona times. It is time saving for the patient as well as for the surgeon and not related to any major complications. Thank you.
That was a good presentation. Only I want you to elucidate what were the indications for which you used the bilateral simultaneous injections.
Diabetic retinopathy, if there was wet ARMD in both the eyes, any choroidal neovasculopathy, and ROP cases were there.
And what was the need to kind of shift from one insulin syringe to another? Are you alicotizing the intravitreals?
Because we used to prick the vial, so the needle might be blunt, so that's why we
could have
changed
changed the needle itself, no?
We used an insulin syringe to.
Okay.
The bevacizumab was used from the same vial in both the eyes?
Yes, sir.
So if the one of the patient is having 1/16 right eye and the 618 or 612 in the other eye, you are giving both the eye the same time of injection.
So if it is required, then.
No, that's what I am telling. Means if the patient is 1/60 lost eye and the other eye is 6/12.
If the patient will benefit with the injection, then we'll give, sir.
Okay.
Thank you.
Call for the next.
Yeah, the second person is Dr. Shweta Parekh, who will present a paper on leopard cannot change its spots.
Good morning, everyone. At the outset, I would like to thank AIOS for the opportunity to present this case. A 67-year-old female first presented to us 11 years ago with low-grade vitritis in the right eye and dense cataract in the left eye. PAN2 was positive, and apart from that, no other major systemic investigations were positive. She was given a course of topical steroids and she responded well. This was then followed by an episode of optic neuritis in the left eye, which again, 3 months later, which again responded well to treatment with steroids. In the following year, she had 2 more episodes of bilateral low-grade vitritis. A uveitis panel each time was non-contributory. She subsequently underwent treatment for cataract surgery and on the steroid cover. She was then lost to follow-up for 7 years and returned in 2021 in January with bilateral diminution of vision with floaters, and vision had dropped drastically in the right eye. AC cells were 2+ and VIT cells were 2+. There was media haze in the right eye and advanced glaucomatous cupping in both eyes with extensive RPE alteration at the posterior pole, more prominently visible in the left eye. Swept source OCT at this time showed epiretinal membrane in both eyes with subretinal fluid in the right eye and subretinal hyperreflective material between the RPE and the Brooks membrane in the left eye, as seen in the image below. And a leopard spot appearance was clearly visible on autofluorescence, more in the left eye, and it was confirmed on FFA as well. She had a normal peripheral blood smear with few nodular opacities in both lower lung zones. CSF analysis and bone marrow preparations did not show any atypical cells. A PET scan revealed of the whole body revealed few hypermetabolic mediastinal and hilar lymph nodes, which on biopsy showed reactive lymphadenitis. She underwent a diagnostic vitrectomy in the left eye, which showed atypical lymphoid cells and was positive for T cell markers and negative for B cell markers. Features were suggestive of a lymphoma. These are her histopathology slides, cytopathology, and this is the IHC showing CD20 negative and CD3 positive. A diagnosis of bilateral primary vitreoretinal lymphoma of T cell origin with ocular involvement only was made. She has received 25 injections of intravitreal methotrexate per eye over the course of a year, and she has experienced corneal epitheliopathy and transient IOP rise, which has responded well to topical medications. At the end of her year-long follow-up, these are her images, and we can see that she is in remission with resolution of the subretinal hyperreflective material. Intraocular lymphoma can be of the primary or the secondary type, and the most common form of PIOL is primary vitreoretinal lymphoma. Around 80% of PVRLs involve the brain subsequently, while 20% of PCSNL will develop PVRL later. More than 95% of PVRL are the non-Hodgkin's diffuse large B cell lymphoma type, and less than 5% are of T cell origin. It is more common between the age group of 50 to 60 years and more common in females. Clinically, it is not possible to differentiate between T cell and B cell PVRL. The clinical features we should look out for include vitritis, aurora borealis pattern, and string of pearls pattern, yellowish subretinal lesions, and sub-RP infiltration, subretinal hyperreflective material between the RP and Brooks on OCT, and a leopard spot appearance on autofluorescence and FFA. Histopathology and IHC are the gold standard. A transpars planar vitrectomy 25 or 27 gauge can be performed. It is challenging. Steroids have to be stopped 2 weeks prior to the diagnostic vitrectomy, and it is a challenging diagnosis to make considering the limited amount of fragile specimen and the low number of neoplastic cells, previous treatment with corticosteroids, and the skill and the experience of the cytopathologist involved. Recent less non-invasive methods that are recommended include performing an aqueous tap for certain genetic mutations. Treatment options include unilateral involvement, ocular, include EBRT or intravitreal methotrexate. For bilateral, there is no established regimen, but locally we can give intravitreal methotrexate or rituximab, or and systemic therapy can be combined with chemotherapy or radiotherapy. So findings to be looked out for include nodules, hyperreflective nodules, clumps, or confluent bands of material. The diagnosis is challenging and it often masquerades as chronic uveitis or vitritis, and it is delayed due to lympholytic effect of steroids. It is necessary to look out for imaging biomarkers of PVRL such as hyperreflective subretinal infiltrates, sub-RPE deposits, RPE undulation, clumps of vitreous cells, and a leopard spot appearance. Thank you.
Very nicely presented, good paper. But just tell me, how would you prognosticate these patients?
So it is difficult, like 5-year survival rate is low considering there is a high risk of CNS involvement subsequently. In PVRL cases, about 80% will get involved later. So right now our patient is, she has just completed her local therapy, and we are keeping her under close follow-up with a neurologist also, considering the fact that she needs monitoring to look out for CNS recurrences.
How expensive is the treatment?
Intravitreal methotrexate, the drug itself is not expensive, so around 3,000 per injection. So she opted for that. She did not want to go for radiotherapy.
And she did not get infliximab?
No, she did not get rituximab.
Very nice.
Thank you.
So our next presenter is Dr. Ramesh Venkatesh. Is he here?
morning, everyone. My presentation for today for this free paper session is Linkoff's rule is not followed in pediatric rhegmatogenous retinal detachment. My name is Ramesh Venkatesh, and I have no financial interest. Let me start this presentation by paying tribute to Sir Harvey Allen Linkoff, who is considered to be the father of retinal detachment surgery. And the reason being that what he gave us is the Linkoff's rules, which are applicable for subtotal retinal detachments, for superior retinal detachments, and for inferior rhegmatogenous retinal detachments. These rules were based on the configuration of the RD, the location of the retinal break, the SRF flow, and the gravity, which is primarily determined by two important factors. One is the vitreous syneresis or the liquefaction, and the second is the posterior vitreous separation. These rules were initially framed in 1971 in adults with rhegmatogenous subtotal detachments and in phakic eyes. However, these rules were further extended in pseudophakic eyes in the year 1994. And what is important is that these rules were framed basically for adult rhegmatogenous retinal detachments. But children are not small adults, and hence the RD in children do not have the same causes, vitreous dynamics, RD configurations, and surgical outcomes. And hence with this study, we wanted to validate the Linkoff's rule in pediatric rhegmatogenous retinal detachments and look at also factors where in cases where the Linkoff's rule were not followed. Coming to the methodology, this was a retrospective study of pediatric cases diagnosed with rhegmatogenous retinal detachments between July 2017 to February 2022, and the documents of these medical records of these cases were scrutinized, and only cases with having good preoperative fundus drawings and accurate documentation of the intraoperative findings were included in the study, whereas cases with poor documentation, combined retinal detachments, and recurrent retinal detachments were excluded. The data documentation included demographic data and ocular data consisting of refractive error, lens status, and history of trauma, and preoperative fundus drawings on the Amsler's chart. This Amsler's chart was done in the OPD if the patient was cooperative, and in the OR after inducing the general anesthesia in cases where the patient was not cooperative for preoperative fundus examination. The retinal findings which were documented were the location of the retinal breaks, whether it is anterior or posterior to the equator, freshness of the RD, the bullousness of the RD, the PVD and the PVR status, and in cases where the retinal break was not identified preoperatively, the suspected location was made based on the Linkoff's rule, which is applicable for the adult rhegmatogenous retinal detachments. The intraoperative notes which were checked were for the primary retinal break and the missed retinal breaks, and then we compared the findings of the preoperative retinal break and the intraoperative retinal break and to check for the validity of the Linkoff's rule in these situations. Coming to the results, we had 98 cases of pediatric rhegmatogenous retinal detachments, of which only 40 eyes could be included for analysis, whereas the remaining 58 eyes had to be excluded. And what you can see from this table is the demographic data of the 40 cases of pediatric rhegmatogenous detachments. And you could see that the most common cause for the trauma was, most common cause for the RD was trauma. And in phakic lens and macula off detachments were most common, with superior detachments, fresh RDs. And what is important is that the preoperative identification of the retinal break was possible only in 35% of the cases, and the preoperative posterior breaks were only seen in 10 out of those 14 cases. Intraoperative retinal breaks were not seen in 8 eyes. That means these 8 eyes had to be excluded from the analysis, and the agreement to the Linkoff's rule was possible only in 9 eyes, whereas no agreement to the Linkoff's rule was seen in 23 eyes. So a Cohen's kappa statistics was done, which was 0.41, which showed moderate agreement, which belonged to the moderate agreement category. When we further analyzed the cases, we found that patients with high myopia, superior RD, and those with posterior retinal breaks did not follow the Linkoff's rule. A further multivariate regression analysis identified the inferior RD and the anterior location of the retinal break was associated with the cases which followed the Linkoff's rule. So coming to the summary, the results, it showed that there was only a moderate level of agreement of the Linkoff's rule in pediatric RDs. The agreement was possible only when the break is anteriorly located and there was an inferior RD, and no agreement to the break in myopic cases, superior RDs, and posterior retinal breaks. Coming to the discussion, the RD configuration basically depends upon the flow of the SRF, which depends upon the location of the retinal break and the PVD status, and therefore the adult rhegmatogenous retinal detachments and the pediatric rhegmatogenous detachments cannot be compared. In our study, in patients of pediatric RDs with myopia, we found that the PVD was present and the location of the brake was more posterior, and hence the Linkoff's rule was not followed in those cases, whereas in traumatic pediatric RDs, the PVD separation was not complete, the anterior location of the brake in terms of dialysis or large brakes, and hence the Linkoff's rule were followed in those cases. The study has got a few strengths and weaknesses as well. The strength being, this is the first study to be reported in literature which talks about the validity of Linkoff's rule in pediatric RDs. And second, and the weakness being the small sample size and the retrospective studies designed because the small sample size, because we were having strict documentation as one of the most important inclusion criteria. So to conclude, Linkoff's rule is valid in most of the clinical scenarios except in majority of the pediatric RDs where it fails to identify the exact location of the retinal brake due to its posterior location and absence of PVD. A careful observation of the retina is a must intraoperatively to find any missed retinal breaks. Thank you so much.
Good paper, Ramesh. Can you tell me what was the age group that you involved in your study?
So, ma'am, the range of the patients which were included were between 5 to 18 years.
5 to 18 years. And the possibility of not finding a break was because they were children and they were not allowing you examination, or was it something else?
So the reason we did not find a break in the sense, so the patients who were diagnosed with the reg RD, they underwent examination in two ways. One, in the OPD itself when the breaks were not visible, and second, even intraoperative, means not intraoperatively, preoperative, after inducing the general anesthesia to the patient, we did the indirect examination and tried to find the breaks. But in some situations, even on the preoperative examination, we were not able to, under the general anesthesia, we were not able to identify those breaks.
Okay.
Thank you so much.
Thank you.
Now the next paper is by Dr. Mahendrakar Anirudh-Dinkar. That is a study patient comfort and the surgical safety with the subtenon block for the 23 gauge vitrectomy.
Thank you, sir. This is our study which sir just described. So here the guidelines for safe and effective anesthesia for 23 gauge or even any type of vitrectomy have not been defined properly. So ideal anesthetic should be the one which is patient friendly, which is safe, effective, and should be also practical to use. Here we have studied retrobulbar as well as peribulbar anesthesia, which has been done commonly, and general anesthesia, which is rare, but in this study we are not including them. Subtenance anesthesia has been used frequently for cataract surgeries. Subtenance anesthesia is considered to be safer because retro and peribulbar have given some serious complications like globe perforation and optic nerve injury as well as retrobulbar hemorrhage. So in our study, we aim to study the patient comfort as well as surgical safety with subtenance block for 23 gauge pars plana vitrectomy. Inclusion criteria were 40 years plus age and vitrectomy for indications other than retinal detachment or complex vitrectomies. Exclusion criteria were age less than 40 years, complex retinal detachment, traumatic conditions, or patients who could not give proper consent, impaired mental status. Retrospective review of 35 patients, including, this is the demographic analysis, 17 males and 18 females underwent 23 gauge pars plana vitrectomy. A complete ophthalmic as well as anesthesia related evaluation was done preoperatively. Topical drops of anesthetic were put. After that, the anesthesia was loaded in the syringe. So we are using a 23 gauge blunt needle, which is a blunt cannula, which is the routine visco cannula that we have. Around 5 ml of 2% lignocaine is loaded. After putting the speculum with the LIMS forceps, the location is identified and a small cut is made to expose the sclera. is around 4 to 6 millimeters behind, not in the port, not in the site where we usually take the trocar cannula insertions. And subtenance, like any other subtenance procedure, the anesthetic is injected there. So the pain perception was evaluated with questionnaire. So no pain was grade 1, mild pain was 2 to 3 grade, moderate was 4 to 5, and more than 5 was considered severe. Mean surgical time, including the anesthesia procedure, was around 34 minutes because these were simpler cases. There was very limited akinesia during this procedure, so the patient's eye movements were there. The male to female ratio was 17 to 18. Intraoperatively, low pain perception was felt by the patient. Almost 80% had no pain, 20% had mild pain, and moderate to severe pain was felt by none. So the post-operatively, when they were asked, they said there was no pain at all. There are disadvantages of this study because there was very limited akinesia. There was no anesthesia-related major complication. During surgery, 97% patients reported no pain. Chemosis and conjunctival hemorrhage were the most common complications. Since guidelines concerning safe and efficacious anesthesia for patients undergoing 23-gauge vitrectomy are not standardized, here we want to discuss the 35 patients that we did for vitrectomy and pain perception in those patients. So preoperatively as well as during surgery and postoperatively, the pain perception was very less. The disadvantage was that akinesia was not there. Anesthesia-related major complications were absent, but chemosis and conjunctival hemorrhage were quite common. Chemosis used to interfere sometimes with the insertion of trocar and cannula, but it did not significantly affect the surgical procedure. So in conclusion, subtenance anesthesia can be considered as a safe and effective and significantly more comfortable procedure for the patient because even during anesthesia the pain was not less, whereas many times patients keep complaining that the anesthesia related pain is significant. So it can be at least in this study done for many indications which are not including significant or complex retinal detachment or complex vitreoretinal procedures. Thank you.
Nice paper. What type of surgeries you have done under this subtenance?
Simple vitreous hemorrhage is the most common surgery. In fact, those cases which were well lasered and we did not need intra-operative laser also.
Did you reinforce the anesthesia, this subtenon anesthesia on table?
During surgery, it was not required to reinforce anesthesia. So simple epiretinal membranes which did not need ILM peelings were also included. So these were the cases.
You injected 5 ml. Suppose you inject 10 ml, probably it will block the ciliary ganglion and you can do complex surgery also. And you can top up maybe after 45 minutes or an hour, you can top up once, that will make it still further. It means practically I think you can do all types of surgeries.
Yeah, that's a good suggestion.
What happens to the movement of the eye when you're peeling the epiretinal membrane?
Yeah,
because if you see the fulcrum is in the center, so when the eye moves to one side, the macula moves to the other side, so that's going to be a problem.
Yeah, that was a big thing. So we did not peel ILMs at all, only the ERMs which had a good raised edge, which we were reasonably confident that we can pick up on table were included.
But even when you do a ERM peeling, sometimes on table you feel like doing a ILM peeling, so that would restrict you.
Yeah. So the
No, I
inclusion,
think the key is probably you should get little proptosis when you inject, then you will get into the right plane
akinesia.
and you will have total akinesia.
That was the limiting factor.
I am using this
The
type.
advantages you feel with this procedure?
The disadvantage is the strict limitation in the number of patients whom we can choose. In fact, the diabetics and others who actually are high risk for anesthesia retrobulbar, we cannot choose in this because we need complex membrane peeling and sometimes elongated procedure for this. So that's a
No, I meant what were the advantages that you got of this procedure vis-a-vis routine injection?
Yeah, so the main advantage was now with everything becoming refractive surgery surgery, even our vitreoretinal surgery also, we want patients to be more comfortable and their experience to be better. So when we are giving an anesthesia on table under the drape, the patient does not feel that feeling of injection. So many times patients do not fear surgery, but they fear the injection. So that perception is changed. And so once the patient's experience is changed, then the patient feels that the surgery is more comfortable.
Biggest advantage I think is high myopic eye where you have globe perforation. With this you can have no globe perforation, you know.
Yeah, but in
And
those
effective
patients,
block.
he is not doing any
Correct.
compensating
Yeah.
That's the
So that's where
What I am doing in this type of anesthesia, I am reinforcing when I am giving the first peripulvar block. And if the surgery is lasting complex diabetic vitrectomy for 3 hours, then after 2 hours I am reinforcing with the subtenon anesthesia. But giving the subtenon anesthesia in the starting point, from my side, it's not a good choice, because if you have to remove the vitreous properly, the eye should be stand still.
yeah, akinesia is the main.
I think we can have the next paper.
Thanks.
Thank you.
Next speaker is Wing Commander Avdesh Oli. Is he here? There, sir. He'll speak to us about modification. Sorry?
Avdesh.
Dr. Avdesh is here.
Next. Dr. Roy, is she here? She'll speak to us about adverse biochemical parameters affecting the response of anti-VEGF treatment in DME. Can the coordinator please try to call up?
A very good morning to everyone present here. My presentation is Novel Biochemical Parameters Affecting the Response of Anti-VEGF Drug Treatment in Diabetic Macular Edema. I have no financial interests. As we all know, the current global prevalence of diabetic retinopathy is 126 million among 382 million people with diabetes. Anti-VEGF came into existence following extensive research and studies. It currently plays a pivotal role in the treatment of diabetic macular edema. However, it has been seen that 15 to 20% patients in diabetic retinopathy do not adequately or fully respond to anti-VEGF therapy and require alternate treatment strategies for their management. Several studies have shown that advanced lipooxidation end products have a role in the pathogenesis of different oxidative-based diseases, including diabetes. Amongst ALEs, 4-hydroxy-2-nonenal and N-epsilon hexanol lysine are the newest biomarkers which have gained attention. Additionally, the enzyme lactase dehydrogenase levels have been significantly associated with the progression of diabetes and also with obesity. The aim of my study was to find out if there is any association of serum levels of ALEs and LDH with non-response to anti-VEGF treatment. This was a retrospective case-control study carried out between the period of January 2020 to May 2021. Patients with both type 1 and type 2 diabetic mellitus attending our OPD were considered for this study. They had received monthly 3 anti-VEGF injection ranibizumab with or without focal grid laser treatment based on the discretion of the physician. The patients had a follow-up at 4 months. The inclusion criteria was greater than 20 years or older patients, center involving DME, in non-proliferative or early PDR cases. Baseline BCVA was between 0.1 and 0.2, and a baseline CMT of 300 micrometer or more, and well-controlled diabetes, that is serum HbA1c levels of less than 10%. The exclusion criteria was any prior vitreoretinal surgery, any prior history of anti-VEGF injections, any significant media opacity, presence of other diseases, other retinal diseases other than diabetic retinopathy, any known cardiovascular diseases, renal, liver diseases, severe anemia or thyroid disorders. The baseline BCVA and OCT was performed at the baseline and at every follow-up visit. Patients were then stratified into 2 treatment groups. They were considered as responders or non-responders. Responders were those patients who had gained more than 5 ETDRS letters or an improvement of more than 50 micrometer from the baseline CMT. Those who did not fulfill their criteria were the non-responders.
All of these patients, their blood levels for LDH and ALE levels were estimated at the final follow-up visit. The plasma LDH activity was measured using enzyme kinetic assay kits and other commercial kits. The ALE levels was measured using ELISA kits. The results were 192 patients were evaluated. Amongst them, 143 were male, 49 were female. The main baseline BCVA score and the CMT scores are as follows. According to BCVA evaluation, 115 eyes were responders and 77 eyes were non-responders. As we can see here, all the patients, both responders as well as non-responders, had a significant improvement in BCVA as well as significant reduction in CMT. In all the patients, the non-responders had higher levels of LDH, higher levels of advanced lipooxidation end products, both HNE as well as H12Y levels. We tried to find a correlation between the LDH levels and BCVA and CMT. A negative correlation was seen in cases of LDH levels. However, in cases of ALE levels, a positive relation was seen in the responders and a negative correlation was seen in the non-responders. Similarly, for ALE HLY levels, a positive relation was seen in the non-responders group and a negative correlation was seen in the non-responders group. So we can see novel biomarkers like LDH and ALE levels showed statistically significant high levels in non-responders compared to responders. Earlier, it has been seen that aqueous sample biomarkers like IL-8 and MCP1 levels were found to be higher, as well as OCT imaging biomarkers like extensive external limiting membrane disruption, traction lateral membrane, drill and ellipsoid zone disruption were considered to be significant, but no known serum biomarkers have yet been detected. This technique of detecting LDH and advanced lipooxidation end products in human blood using ready-made kits is an easier alternative. We detected a statistically significant positive correlation between HLY levels with the final BCVA only in case of responders. Although not statistically significant in responders, a positive correlation was found between HNE and the final BCVA and CMT levels, and between HLY with the final CMT. LDH levels, however, no such correlation significance was found. The limitations of my study were the low statistical power, its retrospective study design, and thirdly, the non-uniform use of focal grid laser could be a confounding factor. Regardless, the study provides a framework for further research. So we can conclude that the serum level determination of ALE levels like HN and HLY could help to predict responsiveness of anti-VEGF injection ranibizumab in diabetic macular edema. Thank you very much.
Thank you. It was an interesting study. Could you please tell us why did you select LDH as one of the biomarkers and why the HLY and HNE? Are there any other advanced lipoxidation products also which can be tested?
No, there was no such indication, but it has been seen that LDH levels play a role has a role in case of diabetes. Other studies have been found, but no such study has been found relating it to diabetic retinopathy. We just researched other systemic illnesses and we tried to see whether this could play a role. So LDH was not found to be significant here, only ALE levels were found to be significant.
Was the LDH level chosen because of any relation with a low-grade pancreatitis which would exist in long-standing diabetics? Was there any such consideration, in which case, of course, even amylase perhaps should have been?
Yes, sir, but we tried to exclude other systemic illnesses. It could play a role in multiple systemic illnesses, but we tried to exclude these illnesses.
And are there any other lipoxidation, products which can be estimated other than HLY and HNE?
We estimated these two circuits only.
But good, very good.
Okay,
thank you.
Thank you, sir.
Is Dr. Avdesh Oli here? Yeah. Dr. Avdesh will be speaking to us on safety and efficacy of suprachoroidal triamcinolone for pseudophakic CME.
Good morning, judges and dear colleagues. I am presenting a modified inexpensive needle safety and efficacy for suprachoroidal triamcinolone injections in macular edema. We all know that cystoid macular edema is one of the leading causes after cataract surgery, which is pseudophakic cystoid macular edema. And we frequently use topical drops in the management. However, in certain chronic cases, we may resort to intravitreal injections. Steroid implants are also used, but they are costly and they can cause glaucoma. Suprachoroidal injection of preservative-free triamcinolone is a recent addition to the armamentarium. Because now we have enough evidence that it is efficacious in various macular pathologies and macular edema, post-inflammation, and even diabetics and retinal vein occlusions. But the problem is that the preservative-free triamcinolone is commercially available at a reasonable cost, but the microneedle is not commonly available. And recent studies on outcome of depot steroid into suprachoroidal space have shown favorable results in terms of improved efficacy, lesser side effects, and longer duration of action. So to fill the gap of availability of a microneedle or a patented microcatheter, we modified a 26-gauge needle along with sleeve of a 22-gauge intravenous cannula for safe and cost-effective delivery. So this is the needle, a routine 26-gauge needle, as you can see. And we have just put the sleeve of a 22-gauge intravenous catheter so that we have a graduated tapered end. And the injections are given 4 millimeters from limbus, like any other intravitreal injection, effortlessly. This is a short video on the procedure. So this is a 22-gauge catheter and the 26-gauge needle. First we have, with the help of a micro scissors, we cut this outer sheath of the catheter into two, so it can be used in two separate injections. And then we pass this 26-gauge needle through this catheter. But we have to make sure that only this terminal 1 millimeter of the needle remains exposed. In most of these 26-gauge needles, the length of the beveled end would be around 900 to 1100 microns. Now, like for any routine intravitreal injection, we mark a point which is 4 millimeters from limbus. And then with this needle with triamcinolone, we hold the needle perpendicularly and apply gentle pressure so that you create a gentle dimple on the sclera. And then without any resistance, you just inject 0.1 cc of the drug, which will contain 1 milligram of triamcinolone. And then, like for routine injection, you can put a drop of betadine, and then patient can be left without a patch. So in these 20 eyes post pseudophakic CME, the mean age was 54.3 years. 60% of the patients were male. Mean duration of topical treatment was 13.8 weeks. They had already tried topical treatment. Mean visual acuity at baseline was 0.52, which improved significantly to 0.06, which was statistically significant. The central macular thickness reduced to almost half to 261 microns at the end of final follow-up at 6 months. And intraocular pressure at baseline and final follow-up was normal. And in this current series of 20 patients with non-resolving CME, the macular edema resolved and vision improved over a period of 12 months. No complications like endophthalmitis, retinal tear, or lens damage were noted. There was no significant change in the intraocular pressure. These are some of the representative images from a patient who has received suprachoroidal triamcinolone. Here in the top panel, you can see the suprachoroidal space filled with the preservative-free triamcinolone. The second picture on top panel is the 3D reconstruction of the same OCT, wherein you can see suprachoroidal space. And the third picture is a UBM with triamcinolone in the suprachoroidal space. And if you look at the bottom panel, we have baseline macular edema. You can see these large intraretinal cysts and see the dramatic response even on day one, wherein more than 50% of these cysts, they have collapsed, and you get a pristine retina at the end of 1 month. So this innovative needle is cost effective. There is no costly catheter or patented cannula which we have used. The material required is freely available and it is safe. And also this has wider applicability in macular edema of varied etiology where cost of healthcare is important concern. And recently this technique is being adopted world over. This is one of the papers published in European Journal of Ophthalmology. And the technique per se was published in IGO and this was published. Thank you.
Thank you. That was an interesting paper. Only thing is which I want you to tell us is that what was the frame of time in which you found the BVCA to be improving after the triamcinolone injection?
Ma'am, the vision started improving by third or fourth day, and by 1 month they had almost reached their final vision. But the most dramatic response was in the OCT, which was on day 1 itself. But by 1 week, the macular edema had reduced to almost half, and the final follow-up at 6 months, none of these patients had residual CME.
And how many cases did you work up?
These
With
were
this-
20 cases.
Out of 20 cases, there were any recalcitrant cases which didn't respond to treatment?
Ma'am, as part of inclusion in the study, we had not taken any other cases which predisposed to macular edema like diabetics or retinal vein occlusion and other systemic or comorbidities or patient on any other drugs. They were simple, uncomplicated phacoemulsification CME cases.
Okay, and all of them you showed a response.
All of them
Was
responded.
there any need to repeat an injection?
No, not in any of these patients. We had 2 patients which were not part of the study. They were diabetics. So we repeated injection at 3 months when the edema started reappearing, ma'am.
So only the tip would be exposed. I think only the bevel where
Yes,
that is only exposed.
That
The
is
rest
only, yes, sir. That exposed bevel would be around 900 to 1100 micron
Right.
depending on the make
So
of the
rest is all covered by the
rest is all covered, and it doesn't allow that needle to enter further.
What is the reason for no increase in the intraocular pressure? Is it because many of these patients were on 13 weeks of topical treatment? So if the pressure would increase, they were weeded out first only?
The baseline pressure was 13.5 in these
Yeah.
patients as a group,
Yeah.
sir. But what I have noted that there could be immediate rise in the intraocular pressure. Immediate, I mean maybe first 24 hours or so. But at any other follow-up like 1 week or 1 month, the IOP was like baseline. There was no statistical difference.
None of these patients, the triamcinolone had migrated into the vitreous.
No,
It
none
was
of these.
only in suprachoroidal
Yes,
space.
we repeated OCT in each and every patient and did a fundus examination. We did not localize any triamcinolone in the vitreous cavity or on OCTs.
Why have you chosen this technique, and what is the comparative more why you have chosen this over the age-old trusted technique of posterior septenone?
Sir, posterior septenone is what, in my limited experience, I feel it's a blind procedure, sir. Sometimes the triamcinolone gets deposited in the subconjunctival space, so it does not actually reach the site of action. Here it is a technique wherein under direct visualization you are depositing the drug, and now there is enough evidence like peach tree, dogwood, they are all trials on triamcinolone in suprachoroidal space. So I felt it is much better than PST injection, but we need to have a head-to-head comparison. Maybe in times to come I'll do that. And other option we have is Ozurdex, and the cost actually for a poor patient is exorbitant, and this is inexpensive for a patient who is in need.
Because what I am doing, I am giving this posterior septenone with the butterfly needle. That's the same needle, and the cannula is going till the posterior part of the globe, and the chances of migration into the subconjunctival space is very, very less. So your technique, your needle, everything is same. Only thing is my triamcinolone is in the subtenon space, you're in the suprachoroidal space. In your case, you are going inside the eye. The chances of complication is there. In my technique, age-old trusted technique, the chances of the complication is very less. So you have to compare both the things.
Yes, sir. And in these techniques, sir, what these large trials they have found, they have done animal studies and now there is a lot of data. What they have found that raised intraocular pressure is very less with suprachoroidal injections because most of the drug that is routed posteriorly. So there are short follow-up studies by those trials. They have shown that more concentration of drug in this technique is found in the posterior segment as comparable to other techniques. That's the finding of their trials. Thank you.
We'll call the next speaker, Dr. Shweta, who will present on idiopathic epiretinal membrane and its novel association with hyperreflective foci.
Good morning, everyone. I am Dr. Shweta Suryakan, and I am presenting a paper titled Idiopathic Epiretinal Membrane and its Novel Association with Hyperreflective Foci. So how did this idea come up? We had a 65-year-old male patient with a nuclear sclerosis grade 2 with an idiopathic epiretinal membrane with a BCVA of 612 and 12. So this was his pre-op OCT picture, and he had a central macular thickness of 335 microns. He underwent an uneventful combined surgery phaco-IOL with vitrectomy ERM peeling. As you can see, the pre and post-op OCT anatomically looks good. The membrane is well peeled, all good, but not really. We see that the central macular thickness increased from 335 microns to 367 microns. Also, the BCVA dropped by one line. So this led to a lot of commotion. In spite of doing a good surgery, if the patient has a drop in vision, there should be some other factor which is playing a role. So we went back to the OCT, and on some keen observation, we found these tiny hyperreflective foci in the OCT, which was not really a described feature in ERM. So we went back to many other OCTs of different patients with epiretinal membrane, idiopathic ERMs, and we found similar findings in many of these OCTs. So this led to the study, the novel association of hyperreflective foci with idiopathic epiretinal membrane. So we did a retrospective study between Jan 2018 and Jan 2020. We chose patients who underwent surgery for idiopathic ERM. Some of them had received steroids, some did not. It was at the surgeon's discretion, and we wanted at least follow-up of 1 month to be included into the study. So all OCTs were done on Swepsos OCT, Topcon, DRI OCT, Triton Plus. Radial scan, 12 into 12 mm centered on macula was what we do. And all OCTs had a minimum sound to noise ratio of at least 35, and all the images were independently graded by 2 observers, and then it was tabulated. We used the Govetto classification to grade the ERM. Stage 1, there was negligible disruption of retinal layers. Stage 2, if there is stretching of the outer retinal layers. Stage 3, if the ectopic inner foveal layers are crossing the central fovea. And stage 4, where there's complete disorganization of macular anatomy. A statistical analysis was done. A p-value of less than 0.05 was considered as statistically significant. We had 13 male patients and 11 female patients in our study. We had 5 patients each in stage 2 and stage 4 groups, and maximum of 14 patients in stage 3. We saw that the mean hyperreflective foci increased as we went up the stage. Also, the mean central macular thickness went up as we went up the stage. So the number of hyperreflective foci was a mean of about 4.2 in stage 2, and it increased to a whopping 59.2 in stage 4. Also, the central macular thickness corresponded accordingly, and both of these values were significant statistically. So let's see 2 cases now. The first case is a patient of stage 2 ERM, where the central macular thickness pre-op was 304 and increased to 332 after an uneventful phaco-IOL with vitrectomy and ERM peeling. And this is another patient of a stage 4 ERM, where the central macular thickness decreased from 554 to 448 microns. The key difference here is that the second patient also received an intravitreal dexamethasone implant. So when we compared the 2 groups, those patients who received steroids and those who did not, those who received steroids had a better resolution of the macular thickness. So these patients reduced from 372 to 283 with 372 to 313 within a month, while in the group without steroid it in fact increased. When we do a head-to-head comparison, the hyperreflective foci also decreased significantly at 1 month, and it shows a very steep drop by 3 months of post-operative period between the group with and without steroid. So what are we really trying to prove here? See, there is one study which speaks about hyperreflective foci in idiopathic ERM, but they do not describe the clinical relevance of the feature. There are few studies which advocate the use of steroids in epiretinal membrane surgery, but they do not have a strong rationale to support this use. There are few papers which speak about the role of inflammation in ERM, but again it is not proven. So our study is connecting the dots. So we now can postulate that there is a role of inflammation in idiopathic epiretinal membrane, which is represented by the hyperreflective foci. Hence, steroids do better. Patients with steroids do better. So, what to do for the subclinical inflammation? Firstly, we have to look for these hyperreflective foci in the idiopathic epiretinal membrane cases. Look for macular thickening. If both these indications are present, we suggest use of intravitreal steroids, especially if the ERM is stage 3 or 4. So that way you have a better central macular thickness resolution, better BCVA, and a happy patient. Thank you so much.
Nice
Thank you,
present.
Shweta. That was a very nice, interesting paper. Only one thing I wanted to ask you is that in your subgroup of patients, were there any diabetics?
No, ma'am, no uncontrolled diabetics. And we did not have any patients with diabetic retinopathy.
Okay.
You have started your paper because the central macular thickness increase in the post-op period.
Yes.
When have you taken that increased central macular thickness? 1 month, 2 months, 6 months, 8 months?
The first image that I spoke was 3 months later, sir.
How much time it will take to normalize the macula after the ERM surgery?
Sir, there will be some manipulation.
No. I am asking how much time it will take the macula to normalize after the ERM surgery.
Sir, it should come back to somewhat normalcy by 1 month. By 3 months, I think post-op edema should have subsided.
More than 6 months it will take.
Okay.
More than 6 months it will take. So your first is you have started the thickness has increased, and the thickness increased from 300 to 332. Some other person is taking the OCT, you are taking some other scan. If you are not at that point, you will find n numbers of variation.
Yes.
So this 32, it's negligible. And the hyperreflective foci, because you are inducing the trauma in the eye, plant trauma, which is causing the inflammation, that is increasing the central macular thickness, if at all it is increasing. But it will resolve. That's why we are giving the prednisolone after the surgery.
Sir, all the other patients who did not receive steroids also received prednisone.
I'm talking after the surgery you are giving.
Okay. Yes, that's
You
the
are
reason
giving
we give
the
topical
steroids or not?
Yes, sir, we are giving.
That is because we are controlling the inflammation, which is because
Surgically
of the plant
induced
trauma.
inflammation. Yes, sir. Yes,
Okay.
sir. Agreed, sir.
And what he rightly said is that you didn't have about a 50 microns difference between the CMT previously and when you started the treatment. So the thing is that you have to have a sizable amount of edema to justify starting your treatment, you know.
Yes, ma'am.
The next,
Go ahead, please go ahead. Please go ahead.
the next is by Dr. Shrey, the lumpy, bumpy, shaggy, speckled condurum, and Dr. Ray Maheshwari. Shrey.
Good morning, everyone, and thank you, AIOS, for providing me this opportunity. My title is Lumpy Bumpy RP Conundrum. We had a 82-year-old female who presented to us in August 2020 with the complaints of diminution of vision, which was associated with mild redness of the eye and mild pain since last 20 days. On ocular examination, we found she had visual acuity of 6/24 parts in the left eye, and anterior chamber had 1+ cells. On fundus examination, the autofluorescence and the fundus examination, we found that there were RPO alteration with pigment clumping along the ST arcade and speckled hypo and hyper autofluorescence in the fundus autofluorescence. When we did the OCT, we found there was exudative RD with the SRF at the macula. And we actually wanted to do a B scan, but this was the time of pandemic and patient was 82-year-old and she was very apprehensive and did not allow us for a contact investigation. So we made a provisional diagnosis of posterior scleritis due to congestion, pain, and cells, and the exudative RD. And we asked the patient for the investigation for RA factor, serum ACE levels, and TB gold test. And patient was started on oral steroid after physician clearance. On the first follow-up, we found that the SRF had actually regressed. So we were hoping that our diagnosis was right. But when we further investigated and did few radial scans on OCT, we found that SRF had actually not regressed and it was just the shifting of the fluid. And we also found there was choroidal elevations and the RPE had some deposits along its line. And finally, we persuaded the patient for the FFA and ICGA. And we found in the early phase of fluorescein angiography, there was hypofluorescence, and in late phase, we found the pinpoint leakage areas. And ICG was hypocynescent in early and late phase. Now, this made us think whether our diagnosis was actually right. Were we missing anything? So we probed the patient again, and we found that she had a history of infiltrating ductal carcinoma, and she was estrogen receptor positive and HER2 negative, and she was on memofen tablet, that is tamoxifen, for last 3 years. So it clicked our mind, and the differential diagnoses were added to it. One of them was choroidal metastasis. So we sent her back to her oncologist, and a detailed systemic examination was done. CT scan thorax, we found mediastinal lymphadenopathy and right pleural effusion. And on CT abdomen, we found multiple lesions in liver, which was suspicious of metastasis. So now a diagnosis of choroidal metastasis was made, and patient was put on palbociclib tablet 100 milligram in a 4-week cycle, 3 week of the treatment and 1 week free, along with the letrozole 2.5 milligram. On the follow-up, we finally found that the SRF had regressed. In a last follow-up, she had improved from 624 parts to 66 parts, and the choroidal elevation had also come down. So the melanoma and the metastasis, so these were the two probable diagnoses that we had in mind. So the basic difference that we would have got was if we would have done the B scan. As the choroidal metastasis, the height-base ratio, as you can see in the B picture, is smaller, and OCTA also lacks the blood flow, and it infiltrates the normal choroid tissue, while the melanoma has a mushroom-shaped appearance. Choroidal metastasis is the most common intraocular malignancy, and it is most commonly seen in breast, followed by lung. 40 to 50% of breast carcinoma patient can have choroidal metastasis. The pathophysiology around it is posterior ciliary arteries have an abundant supply to posterior choroid. Through it can travel. And one is metastatic efficiency index, which is seed and soil mechanism. So the involved organ, the amount of blood flow which the organ has, more the blood flow and more chances of choroidal metastasis. The symptoms and signs that we all should keep in mind is each type of cancer which can lead to choroidal metastasis, they have a peculiar color preference. Like a breast carcinoma will be lobular creamy white color, as you see in the picture B, while picture A shows a pale yellow color, which is basically seen in a lung carcinoma. And as you see in the E, which is an orange circumcised lesion, that is basically seen in lung carcinoid tumor. So if we remember this picture, we can identify which cancer it can be. The basic investigations which are required is B scan, OCT, OCTA, FFA, ICG, and fundus autofluorescence and MRI and tumor biopsy in rare cases. This is the OCT picture that we usually found with the raised choroidal elevation and RPE, lumpy bumpy RPE, as you can see here. And fundus fluorescent angiography, we see in early phase it is a hypofluorescent stage, while in the late phase these are pinpoint leakages. And in ICGA it's hypocynescent all throughout. The various treatment that we have as systemic treatments is immunotherapy and hormone therapy, otherwise external beam radiotherapy, gamma knife radiosurgery, proton beam therapy, plaque radiotherapy, transpupillary thermotherapy, and even photodynamic therapy and intravitreal anti-VEGFs have also been used. So the drug which was used here was palbociclib, and this is one of the very few papers which talk about only palbociclib, irrespective of we have not used any gamma radiotherapy or any other therapy, and patient regressed with the palbociclib alone, along with the letrozole. And palbociclib is a cyclin-dependent kinase which inhibits the G1 phase and inhibits the growth of the tumor, along with the letrozole, which is a peripheral aromatase inhibitors and act on the estrogen receptor. So to conclude, this is one of the few reports which talk about palbociclib, And the take-home message is that history taking should not be neglected, whether it is pandemic or regular OPD, and any patient with history of carcinoma should be screened thoroughly. Thank you.
Okay, thank you. We can have the next paper by Dr. Sunil Kanekal.
Good morning, everyone. Today I'll be talking to you about one of the surgical techniques. There is a fluorescein-assisted subretinal TPA injection for submacular hemorrhage. I don't have any financial disclosure. As we know, the submacular hemorrhage has to be tackled basically to reduce the tractional changes it induces and the toxicity which causes to the photoreceptors. If the submacular hemorrhage is dense, thick and subfoveal, it needs a surgical intervention for clearage. The previous studies have shown that subretinal TPA results are much better than the intravitreal TPA with injection of intravitreal TPA. The main purpose of our study was to assess the efficacy of fluorescein-assisted or a fluorescein-stained subretinal TPA delivery for submacular hemorrhage. This is a prospective study of 18 eyes of 18 patients undergoing pars plana vitrectomy for submacular hemorrhage. 10 patients were neovascular AMD patients and 8 had a PCV. All patients underwent a 23 gauge pars plana vitrectomy. Here a 2 ml TPA in the concentration of 25 microgram at 0.0 ml. This is a 41 gauge cannula attached to the silicone injection thing, and the fluorescent strip is used to stain to get a colored solution. So you tend to get an orange color solution. Once you have done that, a silicone oil syringe with a 41 gauge cannula was then connected to the vitrectomy system, and the injection was titrated to allow the slow trickle of TPA into the subretinal space. TPA was delivered into the subretinal space until the adequate bleb is formed. So you can use the multiple sites also. You can see the clear cut bleb, and you can make out the colored bleb which is very well formed in the subretinal space. Once you are done, you can do a fluid air exchange and inject an intravitreal gas. The primary outcome of this was to assess the successful delivery of subretinal TPA. The secondary outcome was whether the displacement of submacular hemorrhage occurred and the change in visual acuity from baseline. The functional assessment was done with the help of microperimetry and ERG. We defined improvement of best corrected visual acuity as improvement of more than 2 lines on a ETDRS chart. The retinal sensitivity values was measured in mean plus or minus standard deviation. Snellen's acuity was converted to logmar and the statistical analysis was done. The mean age was 72 years plus or minus 9 years. Mean follow-up was around 463 days. There were equal male and female patients. None of the patients had a visual acuity better than 20 by 200. The best acuity, corrected visual acuity was hand motion in 40%, counting fingers in 40%, 20 by 400 in 20%. The average duration of submacular hemorrhage was 4.9 days. Some patients had systemic hypertension and very few had an anticoagulant therapy. 4 were treatment naive. 10 had a previous history of anti-VEGF therapy. 4 eyes had a focal laser plus anti-VEGF therapy. In all the eyes, we had a successful delivery of subretinal hemorrhage. But 3 eyes showed the reflux of subretinal TPA. In them, the injection was stopped and the secondary site was chosen. The bleb formation allowed the space for the subretinal TPA to be delivered to get a good enzymatic activity and resolution of the hemorrhage. SF6 was the main gas used. Post-operatively, the submacular hemorrhage was achieved in all cases except one eye had a submacular hemorrhage. Visual acuity improved from 1.53 logmar units to 1.068. Overall, 9 eyes had a gained visual acuity, 8 had a stable vision and 1 had a lost visual acuity. This was the pre-op and post-op pictures. There was a significant improvement in retinal sensitivity detected by microperimetry. ERG performed at 1 month showed, post-operative follow-up showed 30% decrease in photopic response, 50% amplitude reduction in the setting of recurrent submacular hemorrhage which was seen in one eye, and normal systemic response was seen in rest of the eyes. So the fluorescein sodium eliminated from the circulation occurs usually typically in 24 hours. Previous studies have also shown that retinal toxicity has not been reported with intraretinal or subretinal fluorescein. Hemorrhage displacement was successfully achieved in all the patients. So what are the advantages of this technique is, one is the improved visualization of bleb formation, full weaving of the TPA distribution in the subretinal space, Fluorescein staining of the 41 gauge puncture site allows the re-entry into the same puncture site. The ability to view the reflux TPA into the vitreous cavity allows to quickly leave that site and move to the next site. With the use of viscous fluid tubing and foot pedal control, the surgeon can inject this subretinal TPA in a controlled fashion without any need of an assistant. So in conclusion, this technique allowed us for an improved visualization of subretinal TPA delivery, not associated with a unique toxicity concern or intraoperative complications. Of course, our sample size was small, and we didn't have a much long-term follow-up. With this, I would like to conclude my paper.
Thank you. That was a nice paper. One thing is that the fluorescein strip which you used, do you autoclave that?
It's a sterile strip, ma'am, which is commercially available.
Okay.
The remaining 17 cases in your series, they were worse than this one, or they were similar to this
that one? One which had a recurrent submacular hemorrhage also with pneumatic displacement, it regained the visual acuity, sir.
No, the vitrectomy which you showed,
yes.
The other 17 cases, they had more dense submacular hemorrhage than
more or less, sir, except for the two patients which had a PCV patients which had a much denser hemorrhage than the neovascular AMD patients.
Because the vitrectomy which you showed, at least I would have just done a pneumatic displacement, and
but it was a very thick, dense hemorrhage, sir. That was we thought of going ahead with the surgical procedure.
And the fovea, it was not so much.
Thank you. Let's call the next person. Is Dr. Sunil Ganewalia? Yes. Actually, you're the same person. Okay. You go ahead with your next paper on autologous transplantation of neurosensory retina.
I don't have any financial disclosure regarding its stock. The main purpose of this study was anatomical and functional outcomes following a triple layer graft, so using a neurosensory graft as well as RP choroidal grafts in patients with advanced neovascular AMD which are associated with fibrosis and atrophy. This was a prospective study of 16 eyes conducted over a period of 5 years. None of the patients has received a multiple anti-VEGF injections in the past 1 year prior to the surgery. So the maximum dose of anti-VEGF was tried already in most of these patients. All patients underwent part plana vitrectomy with triple layer, that is neurosensory, as well as RP choroidal grafts. The main indications were hemorrhage in 1 patient, and non-responders in 5 patients, fibrosis in 8 patients, and RP tear in 2 patients. This is a technique which we used. The triamcinolone-assisted PVD induction was done. Then a subretinal injection of BSS was done in the temporal quadrant to induce a retinal detachment. Then a peripheral retinotomy was done to get access to the subretinal space. Once you're done and fold the retina and CNVM removal was done, there was not much use. The minimal gentle cautery diathermy was done to stop the bleeding. The temporal RVS site for the RP choroidal graft, approximately size of around 3 to 4 disc diameter was chosen. Using a bimanual technique, the graft was taken out and placed subfoveally under perfluorocarbon liquid. Since there was a fovea was atrophic, the iatrogenic macular hole was created, and a retinal graft was taken to cover off that fovea macular hole which you have created. Once you have done, unfold the retina, now the main part is moving the neurosensory graft which you have taken onto the macular hole area which you have created. Move it gently towards the macular hole area. And it placed over the RP choroidal graft. Then you can diathermy the neurosensory graft area and do a gentle laser to that area. Then a perfluorocarbon silicon oil exchange was done. The graft was placed subretinally in 12 patients and intraretinally in 4 patients. The size of the choroidal graft, as I told before, ranged from 3 to 4 disc diameters large. Retinal graft, approximately around 0.5 to 1 disc diameter larger than the macular hole. Silicon oil and tamponade was used in all the patients. The follow-up protocol included assessment of best-corrected visual acuity, ophthalmoscopic examination, fundus photography, autofluorescence, and the OCT and OCTA, and the fixation testing was done using a microperimetry. The mean age was around 71 years. The mean follow-up was around 6 plus or minus 3.4 months. The preoperative fixation was based on the reading was absent in all the patients since it was an advanced disease. The mean best corrected visual acuity improved from counting fingers to 20 by 800, which was statistically significant. Vision was stable in 12 eyes and improved in 4 eyes. Reading ability improved in around 7 eyes. Reading acuity improved from 3 to 6 months. So over a long-term follow-up, there was a much better improvement in the reading acuity. Limited subretinal hemorrhage was seen in 2 eyes intraoperatively. Post-op graft atrophy was seen in 4 patients, epiretinal membrane development in 3 patients, and dislocation of graft in 2 patients. None of the eyes developed the PVR or RD. The OCT findings, you can see here clear cut. There is a yellow demarcation line which is seen between the original neurosensory retina and the graft. In the intraretinal group, the graft is very well made out, and it is the edges of the graft, and it very well integrates into the surrounding retina. The edges of the free graft can be very well made out, and even the intraretinal fluid is disappeared in most of the patients, and even the outer retinal restoration was seen in around 14 eyes out of the 18 eyes. What does the FFA and ICG showed? The revascularization of the choroidal graft was seen. On a dynamic ICG, there was a feeder vessel which was seen at the contact of the graft with the underlying choroid, but on retina there was no signs of neovascularization. The choroidal graft clearly seen on the outer octa images. You can see the yellow arrow with this, but the superficial and deep retinal vasculature are preserved in the area of neurosensory retina. As we know that octa was limited by the segmentation and artifaction errors. The autofluorescence graft was homogeneous throughout the graft, and it was maintained up to 6 months, but it started fading on a long-term follow-up. The microperimetry showed significant sensitivity along the margins of the retinal free graft as well as over the choroidal free graft. And increase in retinal sensitivity correlated with the improvement in best corrected visual acuity in most of the patients. Submacular surgical trials have shown that just excision of the transplantation of the RP and choroid is not good enough to improve the visual acuity. So one need to add the neurosensory retina as a triple layer to get a maximum outcome and a better visual functional outcome. So main concerns are, one is if there is an hemorrhage, there could be encapsulation of the graft. And other thing is, if you take an RPE from the periphery, whether the functionality of the RPE in the periphery correlates with the functionality of the macular RPE. Ectopic synaptogenesis, because we don't know how the neural connections work post-graft. The vascularization of the choroidal vessels which develops runs parallelly. But if you look at the normal choroidal vessels, they are radially arranged, not parallelly. So this is one more concern, whether this is abnormal vascularization or does they differ from the normal choroidal vasculature. So in conclusion, even though it's a complex procedure, should be considered in the end stage of AMD patients, but the patient selections, the graft perfusion, the amount of damage to the RP during insertions, and the condition of the overlying retina, especially the outer retina, determines the outcome. With this, I would like to conclude my paper. Thank you.
I think we are running behind time, so let's go with the next lecture.
Thank you. Nice presentation.
Thank you. Thank you.
Good surgery.
Dr. Divya Alex. Kerala Society of Ophthalmic Surgeon. Dr. Divya Alex is there.
Dr. Vibhuti.
A warm good morning to all. I'm Dr. Divya Alex. I am presenting on the paper on early OCT biomarkers to confirm bilateral asymmetric type 2 macular telangiectasia. So type 2 macular telangiectasia, it is an acquired bilateral neurodegenerative disease with secondary vascular changes. The retinal alterations in mactal start at the temporal parafoveal area, and one of the earliest signs in mactal is considered to be the loss of normal foveal hypoautofluorescence. Earlier, the disease was thought to be vascular in origin. Now, all the available evidences point to the Muller cell as the central player. The Muller cell, which is considered as the universal macroglia, span the entire length of the retina and are responsible for the structural organization of the same. The disease considered to follow Muller cell dysfunction and the secondary vascular changes leading to RP migration and neovascular complexes follows later. So, the aim of our study was to find out the early OCT changes in the patients during the early Muller cell dysfunction. So, modalities such as the measurement of the macular pigment optical density or the blue light reflectance are useful in detecting early signs of mactal, but the clinical utility of these devices is limited due to the non-availability of these advanced technologies, especially in countries like India where mactal is more prevalent. So it was a retrospective observational case control study in 293 patients with a diagnosis of MACTEL, and it was compared to 50 age-matched control. Heidelberg Spectralis was used, and the SPSS 26 version was used for statistical analysis. The demographic data were comparable in the study and the control group. Although the MACTEL is a bilateral condition, MACTEL can present and remain as a unilateral condition for a long time. In our study, about 14 patients, that is 4.7% patients, had grossly asymmetric presentation of MACTEL. That means that the characteristic features of MACTEL were observed in only one eye, whereas the fellow eye on its own would not fit into the diagnostic standards both by clinically and by imaging methods, even in the fundus fluorescein angiography. None of the defined SDOCT findings like hyporeflective cavities or ellipsoid loss were noted in any of the unaffected fellow eyes. So what did we find? So there was, what did we find? There was definitive foveal and temporal parafoveal thinning in the unaffected fellow eyes. So this is the color-coded map of the ETDRS circle showing significant thinning in the foveal and the parafoveal region. So the intensity of the blue color points towards more thinning. In affected eyes, it's dark blue. In the unaffected eyes, it's light blue. These parameters are definitely thinner than the retinal thickness data in the control group, where the color coding is in yellowish green, which is healthy. And the other finding was the intraretinal hyperreflective dots that were found in 92.8% of the unaffected fellow eyes. These hyperreflective dots were mostly located in the outer nuclear and outer plexiform layers, and they were very well defined, round to oval shaped, scattered, small non-confluent dots with no backshadowing. And these hyperreflective dots did not correspond to any significant findings in the infrared or fundus autofluorescent images. So we compared the hyperreflective dots in the affected and unaffected eyes of the asymmetric MACTEL. So the crystalline deposits visualized on the fundus photographs, they were more superficial and located in the retinal nerve fiber layer. The hyperreflective dots in the affected eye, this was found more proximity to the disruption of the EZ and in the vicinities of the intraretinal hyperreflective spaces. In this control eye, the dots were found in GCL and IP, and that was minimally reflective only. So the outer retinal hyperreflective dot was found in 92.8% of the eye, and the foveal and the temporal parafoveal thinning was present in the 100% of the unaffected eyes. So our study demonstrated the earliest SDOCT findings in the seemingly unaffected eye with asymmetric disease manifestation of MACTEL. So temporal parafoveal and foveal thinning and the presence of the outer retinal hyperreflective dots were the earliest demonstrable SDOCT finding in the asymmetric MACTEL. As most of the axons and pedicle terminals of the foveolar cones are displaced radially, the parafoveal region mainly contains Muller cells and the glia. So this can emphasize the early degenerative nature of the disease considering Muller cells. So these hyperreflective dots could be neurodegenerative or vascular. One school of thought is that this presence of hyperreflective dots is because of the Muller cell degeneration, and the other thing is that it is vascular. But if it is to be vascular, the angiographic leakage should show some evidence of angiographic leakage due to incompetent capillaries. So our study mainly suggests that these outer retinal dots are neurodegenerative rather than vascular. Considering the fact that Muller cell dysfunction is the earliest pathological process in MACTEL, we speculate that the hyperreflective spots, even before angiographical changes, correlate with the degenerating Muller cell. So this is the largest reported series of asymmetric macular telangiectasia, and the type 2 macular telangiectasia can present in a grossly asymmetric manner, and thinning of the foveal and temporal macular thinning and hyperreflective outer retinal dots can be considered as the surrogate SDOCT biomarkers in the MACTEL. Thank you, sir.
No questions, please. Now the last speaker is Dr. Bibhuti Kashyap.
morning, everyone. So my topic for today would be a new indication for endoillumination assisted scleral buckling, or EASB, a failed vitreoretinal surgery. I have no financial interests. So much has been talked about the scleral buckling and past line of vitrectomy with respect to their individual pros and cons, and how vitrectomy rescues a failed scleral buckling. EASB, a relatively new concept, further increases the scope of scleral buckling to cases having poor break localization due to various causes. Question then arises that in vitrectomized oil-filled eyes with redetachment, by combining the technology of endoillumination to scleral buckling procedure in form of EASB, can a simple, equally effective, extraocular, old procedure come to rescue of a failed modern vitreoretinal surgery? As of today, no published report exists about surgical outcomes of EASB in oil-filled eyes with retinal redetachment. So the aim of the study was to evaluate the surgical outcomes of EASB in eyes with failed vitreoretinal surgeries. It was a prospective interventional case series of 15 eyes operated with EASB in 6 months duration. Baseline characteristics of age, etiology, time since last surgery, pre-op vision, lens status, and PVR grade were noted. Post-surgical follow-up was at first day, first week, first month, and third month, where vision, retinal status, IOP, and lens status were the recorded post-op variables. Patients included in the study were the ones having history of vitreoretinal surgery with silicone oil injection and presenting with retinal redetachment without visible breaks and PVR grade up to C1. Patients with band or silicone tires, history of gas tamponade, visible posterior causative break, fixed folds, or pre-existing glaucoma were excluded. Surgical steps included creation of a conjunctival peritomy and isolation of recti and hooking them with cotton sutures. Creation of a port to fix the endoillumination, and then visualization of break under contact wide-angle viewing system. This visualization was partly hindered by the interfering blood meniscus as well as the interfering silicone oil meniscus. But with careful maneuvers, these hindrances were obviated and the break was accurately localized. Cryopexy was then applied to the break. Followed by a routine scleral buckling surgery, passing of the silicone tires, followed by encircling band, final tie, and peritomy closure. This is done, sir. So this is the pre and the post-operative picture of a patient with oil-filled eye with retinal redetachment whose retina was reattached with EASB. In my case series, 60% of patients were male and 65 were phakic patients. In the 15 eyes of 15 patients, the median age was 48 years and all patients had undergone a single vitreoretinal surgery. Mean time lapse since last surgery was 26 days. Out of the 15 eyes, one patient had fixed fold, one had posterior break, and one had significant lenticular opacity, because of which EASB was aborted and converted to vitrectomy. So basically 12 eyes were actually operated for EASB. Retina was attached on day 1 in 91.6% patients. The BCVA improved significantly across 3 months. There was no significant change in IOP across these 3 months. There was no significant change in the silicone oil meniscus, and no patient developed endoilluminated site-related break or cataract. So basically EASB gives us best of both worlds, firstly by enabling a safe and equally effective rescue extraocular procedure even in difficult media, and secondly by circumventing a repeat intraocular procedure and its associated challenges. Hence, it is a safer choice in patients where a repeat intraocular procedure can be detrimental, as in myopia with vitreoschisis, post-keratoplasty patients, and aphakic patients. Apart from the previously discussed rate-limiting factors of hindering blood meniscus and oil meniscus, availability of a trained wide-angle holding assistant also ensures smoother flow of proceedings.
Despite the limitations of a small sample size, we believe that the initial success rates are encouraging enough for EASB to be considered as a standard rescue procedure for select failed vitreoretinal surgeries. These are my references. Thank you.
Thank you.
Thank you.
We conclude the session.
Yeah.
Yeah. Yeah, please, the next, I think free paper 3 session judges can come.